These presidential lectures, they were created to honor our founding fathers. So we'll get started with Stanley Fahn Lecture Award. It was created to recognize an outstanding scholar and role model clinician in the field of movement disorders. The selected lecture must show evidence of exceptional contributions which have resulted in better understanding of the cause, diagnosis, or treatment of movement disorders and have translated into meaningful improvements in the standard of clinical practice. I'm completely convinced that this year's recipient of this lecture award, he actually meets all these criteria that I have just read. So I really have the pleasure to announce Professor Kailash Bhatia and ask him to come to the stage. So Kailash, before you start, I'd just like to give some pieces of information to our audience. So Professor Bhatia, he is a professor of clinical neurology in the Department of Clinical and Movement Neuroscience at the Institute of Neurology, Queen's Square, London, and an honorary consultant neurologist affiliated to this very same institution. He's a fellow of the Royal College of Physicians and corresponding fellow of the American Academy of Neurology. He received his medical degree and neurology degree from Bombay University in India and obtained further training in neurogenetics and movement disorders in London. So Kailash, many thanks.
Thank you very much, Mr. President and President-elect. It's a real honor and pleasure for me to receive this. If I can make a start here. I don't see the slides.
So can we have his slides up?
Yeah, okay, great.
Thank you.
So I chose this title for Stanley Fahn oration, Back to the Future, Is the Clinical Phenomenologist Obsolete? Now, if you think about the MDS, the society, and the discipline of movement disorders, this is actually quite a recent discipline. It started in 1985 by these gentlemen who are all well known to you, some of them over here. And then a strange phenomenology over here, these two gentlemen, and Stan Fahn, of course. These two were instrumental in bringing out for us this new discipline with regard to phenomenology. If you look at the textbooks, you don't see movement disorders mentioned. So as clinicians who took up this discipline, we had to evolve. We had to learn how to do phenomenology. What do we mean by hypokinetic and hyperkinetic and all of that, which you're now all familiar with, and the syndromic approach, and of course the etiology. So we had to develop this skill, and it was because of these people. So that was in the recent past, but now the current and recent past is the age of genetics. All of you know about this terminology. Variety of different things going on in this field, which have been advancing our field. And this has led to some difficulties and challenges as well. So you have one gene giving you many phenotypes, one phenotype being caused by many genes. And this is not just in genetics, but I think under the radar also to a little lesser extent, antibodies. So a number of antibodies being described, very similar to what we see with the genetics, where you have chorea or dyskinesia described by different antibodies, dystonia, etc., etc. So very similar parallels here with regard to genetics and autoimmune disorders, and almost every day some new, a new antibody is being discovered. So this has sort of led to some frustration, perhaps, even a lack of self-belief in the clinicians. Some question their role as a clinical phenomenologist. Some even say that genetics will be like imaging, and people will bring their genetic readout before they come to the clinic. So we have to ask ourselves, if we are thinking about this, is the clinical phenomenologist obsolete? And of course, I don't have a conflict of interest. And I say no. Not for the moment, and perhaps never. So my take to you here is that in this era, just like we did at the start, the clinician will have to adapt to the new reality. And the clinician has to evolve again. And we need to have the evolved clinician, keeping in mind this. So at the end of this talk, you should be able to tell all these genes and the genotype-phenotype correlations. So, of course, I don't expect you to know all the genes which are being described. That's impossible, and we are not going to be able to do that. But what I do want you to say or think about is that the clinician needs to be involved in the genetics in these three ways at least. The interpretation and application of this genetic data which you're receiving, developing and recognizing core phenotypes as they become more clear for at least the frequent genetic conditions which we may encounter. And then eventually, I think we will also be using the phenotyping to molecular pathways and to precision medicine. So I'm going to show you some examples of that. And just before I do that, I just want to mention to you this 100,000 genome project, a very ambitious project which started off in England and where they have received some data already. 100,000 genomes were done, 85K plus participants. But what was the take from that? 18.5% only of data from the project turned into actionable findings. Just 18.5% with a lot of money. Of course, this is an evolving thing, and there may be other discoveries coming about, but it is something you need to keep in mind. And we have contributed ourselves, many patients into this. These are 2 patients taken from that. You can't see the patient, of course. And they had complex dystonia, and this is the readout we got. And we sit in the room with the geneticists, and they say, well, we looked at our in silico prediction, this, et cetera, has anybody seen anything like that before, is what they ask you. They've done their Google searches, but who puts things on Google? Who puts the clinical description? It's you and me. So if it isn't there, then they can't tell you which of these is relevant. And this is the problem which I think we are facing more and more. So just coming back to this interpretation and application, I just want to give you some examples. And again, no conflict of interest. These 2 gentlemen who are not particularly good clinicians, no, very good clinicians, they also did something what I'm doing today, telling us about genetic techniques. Will they obviate the need for a clinical expertise? And the very first patient they mentioned is a patient who had genal, but actually the dystonia was related to a neuroleptic drug. And here is one of our patients. She's been sent to me as a person with a neck dystonia, and she carries a variant in genal. Now already you can see this phenotype is a bit odd. She's got fixed dystonia of the neck. She's too young to have cervical dystonia. So I ignored that finding, and almost immediately with a very small amount of botulinum toxin, her neck is straight, and this is clearly functional dystonia. So the interpretation of that genetic result still applies to you, the clinician. And in this context, I'm sort of bringing out to you 3 cases here, actually from the time, all 3 of them from David Marsden's time. All of them have this syndrome of benign hereditary chorea, and we had tested them for the benign hereditary chorea gene, which is the thyroid transcription factor 1. Now, if you see here, this gene is also called the thyroid lung brain syndrome. And there were certain things about these cases which were peculiar. So we had tested all of them for this gene. It was negative. Here, in this lady, for example, the daughter had early lung disease. So we said, okay, it fits in with the benign heterochorea due to the thyroid transcription 1. The mother had a pituitary hyperintensity. And this is known in patients with the NKX2-1 gene. And yet, directed genetic tests with panels and NGS were unrevealing. But from the clinical point of view, I was convinced that this is related to this particular gene. And very recently, Francesca Magrinelli found an insertion, an ALU insertion in this gene, and this is the cause of this disorder, and it was in the benign heterochorea NKX1 gene. So the clinical features here made us persist to find the genetic abnormality. Now, in the second case, there were again some peculiarities. The son was much more affected than the father. They got nocturnal bouts of increased movements, which were very peculiar. The son found that he was better with coffee. Initially, the errant gene, which was detected in the son, was not found in the father, which was a bit puzzling for us as to what was going on. And the gene which we are talking about here was the ADCY5 gene, and these people are known to have this disrupted sleep, nocturnal ballistic bouts, which this man was having. Coffee can help these people. So all these were phenotypic things which we had picked on, and there is phenotypic variability, as we had found in this family. The father was less affected, and that was because of somatic mosaicism of the ADCY5 gene in this particular family. So using the clinical phenotyping, the clinical clues, we were able to advance the genetic and persist with that to find out what was the genetic abnormality there. And this third lady had a particular brain scan, which was the striatal hyperintensity bilaterally. So this lady was found to have the PDA10A genetic mutations, which are typically associated with bilateral striatal lesions. So we can now then think about, if you then review this as deep phenotyping, you can actually say that in the three most common forms, in the first one, as you see over here, you can have chorea myoclonus, thyroid or lung disease. MRI shows you the pituitary abnormalities. ADCY5, they have this disturbance in sleep, they have somatic mosaicism, and the phosphodiesterase-related chorea. This almost invariably has the striatal involvement on the MRI scans. So although one gene may cause many different phenotypes, the core phenotypes, however, remain true. When you think about your patient with Huntington disease, for example, the core phenotype of the eye movement disorder, the dementia, the chorea, remains true. And we have to discover the core phenotypes, at least in the ones which are frequent disorders which we come across. So we don't need to know about each and every one of them, but certainly in the ones which are frequent, we have to know that. This is also true for the antibody-mediated conditions. You are not going to be forgiven nowadays if you don't know the classic phenotype of the NMDA receptor antibodies. You have to know the facial-brachial dystonic series, which are due to the LGI1 antibodies. I can't imagine that this is sort of has to be there in the training as basic information, because these are treatable disorders, and one has to evolve to learn this. Other important thing here, I think, in phenotyping, in these days with so much movement across the borders of populations, etc., is recognizing ethnicity, particular phenotypes in particular populations is becoming crucial. So this is, as you can see here, Afro-Caribbean woman who has come to us with marked apathy, Parkinsonism, said to have an atypical Parkinsonian condition with an eye movement disorder. She's extremely slow, she's cognitively affected, and apart from the Parkinsonism, she had a little bit of chorea. She's Afro-Caribbean, and there was a possible family history, so people were wondering about Huntington's or an atypical Parkinsonian condition, but because she's Afro-Caribbean, we looked at the junctophyllin HDL2 genes, which is common in South African patients and of African ancestry. So the the fact that she was Afro-Caribbean, and even though it was presenting with Parkinsonism, HDL2 can present both with chorea or Parkinsonism, and one has to be aware of that, and one has to look for this, and they can even have an abnormal DAT scan, which was present in this lady. This is one which I like a lot, the surname tremor. So I see this patient, he comes with this tremor, and I get his surname, which I'll tell you in a minute. He was sent as having Parkinson's. He had also a lot of gait instability. This lady here also sent as a dystonic tremor. She's got some voice tremor. Can we have the sound here, please? Or said to have essential tremor. And both of them have the same surname. They are of Indian descent. And these people have SCART12. And you can diagnose that from the surname. This disorder happens in people of Indian origin in a particular community, which is Agarwal. So if you see an Agarwal coming to you with tremor, the likelihood of SCART12 is extremely high. It's just an observation which you just need to know. And there are now a number of ethnicities you need to keep in mind in movement disorders: Ashkenazi Jewish, Parkinsonism, LAC2, North African Arabs, LAC2, XTP, Chinese, PKD, PRR2, and a number of recessive disorders which happen in certain communities where there is increased consanguinity. Now, in that earlier paper which I showed you, with Tony Lang and Capelsetti saying there is a need for the clinician, of course I ignored the other one, where Vincenzo Bonifati said, we don't need the clinicians anymore. But he also, in a way, I think, negated his own statement by telling us that there are so many problems, technical problems, with the genetic testing nowadays. So, for example, the mutations in the non-kidney regions are non-accessible. Other mutations like gene duplication, deletions are difficult to detect. Every individual may have this whole variety of different variants, and it's difficult to know which of them is causative. And the current in silico tools are imperfect, so we are left with these so-called WUs, and we don't know variants of unknown significance, and we do not know what to do with that. Just to sort of exemplify this as to how genetic testing can sometimes be misleading, and this is a wonderful case given to me by Astrid Andermes from Seville. So there's a lady with ataxia, apraxic eye movements, perioral chorea, and a sensory neuropathy in a family with consanguinity. So they obviously investigated her and thinking about recessive ataxic disorders, and she was found to have a heterozygous pathogenic variant in the PNKP-related gene, which causes ataxia with oculomotor apraxia type 4. And they were looking to see if there was a second variant, because this is a genetic disorder, a recessive disorder. So the brother was also affected. And if I can have the sound here, please. If I can have the sound. And the brother coughs. He coughs all the time. And the cough is the giveaway. And this is canvas. So they have RCF1 biallelic repeat expansions. And very typically they present with ataxia. So just picking up that cough in the brother, and this would have been missed, because if you do exome sequencing, you don't pick up these expansions or triplet repeat disorders. So you need to be aware of that as clinicians as to what are the limitations of the genetic testing which we are doing. This has just come out in JAMA Psychiatry, and it is actually meant for psychedelics, but I thought it's a good one to apply everywhere. The hype cycle. So you get a new technology which comes in, there's a peak of inflated expectations. Then there's a trough of disillusion, the woos and the hours over here. And I think this is where we need to go together with the geneticists. So we should have a cooperation with them, and as clinicians, so then we can come to this plateau of productivity. So does good phenomenology and accurate diagnosis matter? If you ask a common clinician and say, they will say to you, what's the point of doing all these genetics and tests? It's not going to change my management, is it? There's no cure for most disorders. And people tend to work with generic syndromes, and they do generic treatments and managements. However, precision medicine is already here, even perhaps unknown to us. This is what most people do. They sort of think about the syndrome, there's Parkinson's or Parkinsonism, tremor. These are the sort of standard treatments they are using, dystonia, anticholinergics, and maybe DBS. But if you think about it, here you have a patient with dystonia, and you have gone to DBS, and you've done your DBS, but you find that your patient didn't do well. And the patient didn't do well because that patient perhaps had one of the genes where they don't do well if they have that gene, even if you do DBS in them. So for example, TAP1 or for example, DYT12, they don't do very well. But TOR1, for example, would do extremely well. Myoclonus dystonia would do very, very well. So the outcome of your dystonia DBS does depend on what the underlying gene might be. And as I said, the precision medicine is already here. We are talking about the development of gene-specific treatments. There have been some difficulties, but I'm sure there are curative treatments on the anvil, or at least disease-modifying treatments, perhaps. A large number of treatable rare disorders, metabolic and others, are already present, and you need the genetic test to prove them, DRD, GLUT1, Niemann-Pick type C. You also are obliged from these genetic conditions to anticipate of what may come, to screen for given disorders. For example, increased cancer risk in ataxia telangiectasia, or liver dysfunction in the unrecognized SIBS in Wilson's disease. And I believe that very soon it may become mandatory to recognize and follow up with appropriate steps for the correct management based on genotype, phenotype. It will become, you can already see that if you miss DRD, it's a medical legal case. So this is already there in precision medicine. And I want to end by showing you two examples again of where phenotype and precision medicine is important. So this is a patient with corticobasal syndrome in a very nice journal called Movement Disorder Clinical Practice, who had anti-IGLUN5 antibodies. Now, somebody presents to you with corticobasal type of syndrome and has a parasomnia, like REM or non-REM. You don't expect that in conditions like tauopathy. That's a red flag. And if you pick it up and say, okay, send for the IGLUN5. And why is that important? Because we used to think that these people can't be treated. There is no treatments for IGLUN5. But this is a remarkable case. I don't want to sort of show you in detail because of the time. But this patient actually, after IVIG, so here she has difficulty putting her shoes on, and then after IVIG, she has improved in her corticobasal features. She's not cured, but she's definitely better. And what is remarkable here was that even her DAT scan improved. So this is somebody thought to have a degenerative disorder, but picked up because of the phenotypic associations which you see, which were led to them testing for IGLUN5, and it has a very significant, major, important treatment aspect. And similarly here for a rare condition, AADC, which presents with typically with oculogeric crisis, delivery of gene therapy led to improvement of the clinical phenotype, and the patient's oculogeric crisis also improved. So my final message to you is, in conclusion, we need more Stan Phans. The clinical phenomenologist is needed. Thank you very much for your attention.